countries, bringing different kinds of innovation into the health something. I'm having a problem with trying to move on from here. Oh, okay. What has happened? Hello? Hello?
Yeah, Prof, we can hear you.
Yeah, but I'm not even able to share my screen anymore. I think I'm tied up somewhere.
Can they Hanley, can we take over and present?
Well, Hanley, can you please from that your end? Sorry about that. Hello, Hanley? Okay. I don't know what is happening. Okay, this seems to be working now. So we're looking at a few, I said COVID-19 has spurred heavy innovation in Africa, in different parts of Africa. And we've seen 57% of this technology have been ICT driven. They have the example of WhatsApp chat box in South Africa. The self-diagnosis tool that they have in Angola. Ghana is using a contact tracing application. Well, we have a mobile health intervention, which we call telemedicine within Nigeria. And for home isolation, you can see some of the pictures where on this side you have the drone dropping in some medicine in different parts. So that's in Ghana. They're using it for sample collection and also the other situation. At the bottom picture, you see what is happening in Rwanda, in which, again, to avoid all the contact of people with COVID, they're using robots in that place there. And some of them have been based on the 3D printing. I'm not going to too much details in all that, but just to let you know that drones have become quite useful in many parts of Africa in assisting with the health. I'm particularly focusing on Rwanda, which is now I'm told creating its first digital universal primary healthcare service in which everyone over the age of 12 in Rwanda will have access to consultation with doctors and nurses through their mobile phones and within minutes. And the system would then reduce the delays in accessing appointments and the need to see doctors or to travel many, many distances to where the health centers are located. I'm looking at, I wanted to look at that tech solution have actually helped in eradicating wild polio in the African region. So you can see that it's something useful. I'm giving a good one or two examples. The GIS mapping, those of you who know about Nigeria, it was the last country to eradicate polio. But the reason, part of it was because of the insurgency, insecurity, difficulty to reach places. And so all these new techniques were introduced, that GIS mapping, which allows people to use the data management with their mobile technology, go in there with their phone and what we call the GIS technology. You can combine that together for people to work on the office, even though the people who are at the site, which is not accessible, have their cell phone and can pass this information directly to where action can be taken. There's one what they call the AVADA, which is called the audiovisual AFP detection and reporting. The solution to polio eradication was in ensuring that the acute flaccid paralysis cases are detected. But if you're in areas where you couldn't access because of insecurity, then you made use of the people there using this AVADA system to actually get the information right down to the center where action can be taken. And I think that's one of the third one was what we call the e-surveillance, which is an electronic surveillance for real-time monitoring of what is happening on the field. People, there are problems in the field, usually to take, by the time you write letters and put papers, it may take 4 or 5 weeks, by which time it will be too late to do anything. Right now, the e-sub gets information immediately to those who can act, at the headquarters, who can then relay back to the national or local authority who can take action immediately. We have the digger elevation modeling, which is environmental surveillance when we're not finding polio anymore, but people were still shedding the virus within the system. And it's only by using what we call the environmental surveillance that we're able to do that. The other part of it was also the electronic tracking of vaccination campaigns, because that was the whole crux matter to ensure that people are no longer transmitting the disease. So these are factors. Now, encouraging more innovation in the system is something we need to look at, and therefore there is need for us to develop that culture of innovation, a mindset for innovation, not to sit down by the old system that we know, which has at least its usefulness. And we must begin to identify areas. Where are the problems? What can we use technology to solve? Then it must be part of the strategy of health system to look into innovation as a core part of health system delivery. And then ensure that you have a governance structure, I mean, which is following the normal system, not a parallel governance system, but making use of the existing governance structure to imbibe and embed innovation into their activities. There's the need for collaboration because technology involves those who are outside of the health system, it involves business people, it also involves the health sector. So all the three factors and the society, we should be able to accept and receive the innovation. We must all come and collaborate and work together. And then we must look at not just the regular situation when we talk about think out of the box. I often say we should get out of the box. Thinking out of the box is still a constraint. Get out of the box, think freely. How can we solve this problem? And then don't start your innovation doing everything at the same time. Pick out what you can easily do and get a result. And politicians, the private sector, and scientists, we need to dialogue constantly about what new things are coming out. That can be of use to the society. And how would the politicians take that and implement, along the line? And we need to then, for one of the greatest problems that scientists have is the language. We seem to have a little bit of problem trying to relate to the people from the language of science to bring it to a level where people can then understand and appreciate the goodness. The question is, what is a win-win situation for everybody? We must go out there and let them know that there's something to gain. The politician has something to gain by improving the life of the people. The businessman has to gain because if he puts his money into that investment, and the scientist, of course, gains because that is your job, your relevance to your people. It also becomes an important thing. I think one area of which we need to look to quickly is the area of social innovation. We need good governance. We need transparency and we need accountability. All of these have to work in together into bringing this. And I'm making a point that more African nations should also begin from now, move from the manual paper system to the electronic system, take advantage of that in conducting our elections and transmitting election results. In that way, we can use innovation to curb corruption, increase confidence in the trust in the government, and increase the situation that goes on. So I want to say my time is up. I just want to thank you. I'm looking forward to the second one because I know this one is very, very successful. Thank you very much, especially to the organizers of this first meeting. Thank you, and this is the end of my story. Over.
Thank you, Professor Tomari, and thank you for keeping strictly to time. I appreciate your whistle-stop tour through the areas of innovation that we've seen and the potential for innovation to improve access to healthcare and quality healthcare across the system. So I have one question. You referred to the necessity for a dialogue between scientists, entrepreneurs, and politicians to actually translate into actually create a culture of innovation in the health system. So with your experience leading scientific and health institutions and professions for a while and engaging with government, what would could you give us maybe one or two practical things that, how do we actually create that culture? How do we engage with politicians so innovation becomes the norm?
Yeah, thank you very much. I think the scientist on this part has to identify what kind of innovations and how they relate to improving the life of the people. Now, taking that message at your meetings with the politicians is very difficult. Innovations are usually resisted by people because something new, you are used to something, you don't want to change. So it is important for you to let them see that what you're bringing is going to make their life better than what it was. To make your life better than what it was, and so that you can then get that out to the people. And the government itself must be able to see, what am I gaining from it? If they gain the people's trust, if they gain the people's confidence, then of course that's something a win-win for them also, because that's what they're looking for. They like to be, whatever. So that's where the dialogue comes in. And that's why I said the fact that we as scientists must be able to get our language to get to the people who will implement it and to the people themselves who will accept that. I mean, that's the only way. We need to constantly dialogue. It's not just a one-off thing. Consistently looking at those areas, looking at the life of the people, see how we can improve them with innovation. Thank you very much. Oh, I lost you.
Thank you very much, Professor Tomari. That was a very clear answer and a very quick, informative presentation. So without further ado, I will move us straight on to our next speaker. I'm pleased to introduce Dr. Justice Novignon, who is the head of the Health Economics Unit at the Africa Center for Disease Control and Prevention. Justice will be talking with us, will consider how we address health economics modeling to support effective COVID-19 response in Africa. Dr. Novignon, over to you.
Thank you, Ibere. So the events over the past 2 years have taught us that it is actually very difficult to isolate the economy from health or economic issues from health. Because we know that one of the topical issues over the past couple of months has been affordability of vaccines and vaccinations, particularly in the context of low and middle income countries. So how can health economics modeling help us optimize the decisions that we take as far as the COVID-19 response is concerned? I will share with you a couple of examples of how the Africa CDC Health Economics Unit has worked with partners, to generate some of these the evidence to support decision making. So, what we try to do with a couple of our partners is to ask ourselves, what if African countries are unable to meet the vaccination targets? So 20%, 40%, 60%, whatever the targets are. What are the health impacts of not meeting these targets? Over a couple of months, and then June 2022. So what you see on this slide essentially is modeling the different scenarios. So ROS represents the rollout strategy. So ROS 1 simply is 20% vaccine coverage, and then 40%, and then 60%, and so forth and so on. But you would see also that the first bar you see represents no vaccine, a situation where there really isn't any vaccine. And we model this over symptomatic infection, severe cases, and deaths due to COVID-19. What you will see in each of these boxes is that clearly, higher coverage, higher vaccination coverage is better because it reduces the particular health outcomes, and this is consistent for all the outcomes. So this is clearly one way of helping countries see, understand the what-if scenario. What we can do from this also is to look at the economics associated with this meeting of these vaccination targets.
Justice, we're losing you slightly.
Countries are faced with the vaccinations. Can you hear me? Am I back now?
Yes, you are. Continue.
Okay, thank you. So this slide shows from the World Bank, that at 70% vaccination coverage, the per capita costs of vaccination coverage actually exceeds the annual domestic health expenditure for most of the countries. In some cases, up to 5 times. So again, affordability of vaccination is a problem for many countries. How exactly can health economics help, decisions in this response? We do know that the focus has had unprecedented, burdens on public health policymakers. But while we look at improving public health outcomes, it is also important that within our context, we will also look at the economic ability to be able to meet these outcomes. Health technology assessments is a framework, that is used under health economics to help us gather evidence about the properties, but also the impacts of different health technologies to help us decide whether it's important to introduce or not introduce these technologies. And we have seen a lot of the epidemiological modeling of the vaccine impact. But what we propose now is that economic plus epi modeling is a more powerful tool that helps policymakers in making decisions. Economics concerns, comparing the benefits and the costs and looking at the trade-offs in allocating resources that are already scarce. to specific health services. And so health economic modeling helps us to project both the health, but also the economic impact of decisions that we take as part of the response. This can actually help countries and regions, even at the continental level, to make optimal decisions as far as resource allocation is concerned. So the Health Economics Unit at Africa CDC was established in November 2020 with 3 pillars. One, to strengthen health economics capacity to support decision-making, not only within the Africa CDC, but also at country levels. And 2, to generate, and actually in most cases, mobilize existing evidence at a level that could be used at the regional and continental level. And then, of course, double up efforts to promote the use of health economics evidence. This is an example of the things we've been doing over the past year at the Health Economics Unit at Africa, determine the costs of pre-travel screening measures, pre- and post-travel screening measures, using 5 countries, in each of the AU regions, for example. We are also working with the African Health Economics and Policy Association and then the UNECA to assess equity considerations about the COVID-19 vaccine rollout in Africa. In Zambia, we are working with the ministry and stakeholders to determine what returns there are on investment in national level laboratory services, but also regional level laboratory services, not only for COVID-19, but also for public health generally. And the other bit of work we are doing is working with Ethiopia, Nigeria, and Kenya to use health technology assessments in supporting, decision-making COVID-19 vaccine rollout. In all of these cases, we use a bottom-up approach where the key policy questions actually come from interactions with policymakers, national level policymakers and researchers. And then, of course, at the continental level, we work with the different CDC divisions to ensure that these policy questions also can be harnessed to address some of the issues at the continental level. So let me, end my presentation by focusing on one of the countries that we've worked in as far as the COVID-19 vaccine HTA is concerned, which is Nigeria. These are some of the policy questions we sought to address in Nigeria, but also in Kenya and Ethiopia. For instance, which COVID-19 vaccines present value for money? What is the optimal COVID-19 vaccine delivery method? And what is the cost effectiveness and budget impact of vaccine delivery among different age groups? So you would say that each of these policy questions is framed along the lines of the health, but also the economic impacts of the rollout. On this slide, I would like you to focus not mainly on the content, but simply as an example of what health economics modeling can help us optimize COVID-19 vaccine rollout decisions. So what you see on my left, the first graph, is essentially comparing the incremental costs, but also the incremental health effects of the different vaccines. Vaccination using the different vaccines that these countries used at the time. Moderna, Pfizer, J&J, AstraZeneca. Which of these vaccines actually, compared to the economic situation of the country, presents the best value for money? In the middle graph, what we do is to now focus on the vaccination strategies or vaccine delivery strategies, whether they are health facility based or campaign or targeted campaigns for that matter. And again, you would see the different dots show where on the plane each of those vaccines, but also vaccination strategies fall with respect to whether they present good value for money for the country. And then, of course, the final graph shows that by different age groups. So we are looking at what if the country decides to vaccinate 25% of adults in combination with other age groups. So again, you'll see the different age groups here. These are still work in progress. But what I wanted to really share is to see how, in addition to all the modeling and everything else tools we are using, health economics modeling can help optimize the decisions we take as far as COVID-19 is concerned. This is my last slide. And what I really want to highlight from all of this is that economics is very important in helping us, support the decisions we take. Because no country has been able to prove, especially in lower middle income countries, has been able to prove that we can do all this by ourselves. Resources are scarce. They are not enough in the quantities we want them, given the other competing priorities. So it's important that we take advantage of economic modeling. The establishment of the Health Economics Unit at Africa's CDC is actually a call to action, not only at a continental level, but also action by country level policymakers, to take advantage of what health economics can offer, particularly within this context, seeing what COVID-19 has brought us, that we really need to, take our decisions within the context of the resource constraints. The Africa CDC Health Economics Unit and partners can actually help, mobilize the support that is required at the continental or regional level to support any vaccine delivery decision, but also can facilitate, to support countries and specific regions by mobilizing health economics capacity from within countries or within the region as close as possible to the countries, so that we ensure that within the context of actually reducing health resources, we can make decisions about the response and about public health in general that optimize population health at the same time, account for the economics issues that we have. I want to thank all these partners that have worked with us over the past couple of months to bring this and other pieces of work that we are doing together. And I thank you for your attention.
Thank you very much, Dr. Novignon, and thanks to my first speakers for keeping promptly to time and actually giving us a minute for a question. So, Justice, I have one question. As we know, the Abuja Declaration, taken over a decade ago, for African countries to invest 15% of income into health, I think only one country has actually achieved that. Most countries have not. So my question is, do we think that using economic modeling data to actually show the cost benefits of some of investment in health might actually be part of what Professor Tomori alluded to, which is developing a common language with politicians and policymakers?
Precisely, Ibere, you hit the nail right on the head. What we have done, or what we have not done well in health, is to focus most of our actions on health and the ministries of health. But we do know that payment comes from ministries of finance. They understand the language of economics. They would ask you, okay, you can meet this target, but what is the return on any investment we put in there? Or does this present value for money? Is this cost effective? Is this a better use of money resources? And that is what health economics has to do. I think that countries would need to move a step further to generate economic evidence and use that to advocate, as far as ministries of finance are concerned and other stakeholders really, because economics is a very powerful tool to make beyond the health impact when you are dealing with people who would put in the money and are looking at what they have. So I think that, yes, if we would take economics and economic modeling, a bit more serious going forward, we will likely see many countries, at least we will be able to get many countries to put in a bit more to help, hopefully.
That's wonderful. Thank you very much, Justice. And thanks again for keeping to time. So I will hand over now, just to mention, colleagues, if you're having bandwidth problems, please, after introducing yourself, feel free to switch your camera off so that we can maintain the sound quality. And without further ado, I will hand over to my co-moderator to take us through with the next speakers. Dr. Abdulaziz, over to you.
Thank you, my excellent and able co-moderator, Dr. Ibere. I'm Dr. Mohammed Abdulaziz. I head the Division of Disease Control and Prevention at the headquarters in Addis Ababa. I'm also the acting head of surveillance and disease intelligence division of Africa CDC. So we've had two excellent presentations. We will have two more presentations that will prove to be excellent also. We will now move to Dr. Kate O'Brien. I'm now honored to introduce Dr. Kate O'Brien, the Director of WHO's Department of Immunization, Vaccines and Biologicals, who will discuss whether lessons from COVID-19 vaccinations can be transferred to implement adult vaccination in Africa. Dr. O'Brien, welcome and over to you.
Thank you so much, and I'll try to share my slides now. And I hope they're on slideshow mode. Now, can you just confirm that you can see them on slideshow mode?
Yes, but if you can increase it's a little right at the center. Maybe
it's not yet on slideshow.
It's not yet. Oh, now it's on slide mode. All right.
I think just a little delay. Thank you so much. And I have such an honor to be here. And obviously, you know, so much of the conversation is about actually deploying COVID vaccines, but there's been much talk about the opportunity to use this massive deployment to implement and strengthen the adult vaccination program. So what are the lessons that we can learn, or what can we even envision are the things that need to be focused on? I'll just spend 15 minutes with you looking at what some of these opportunities are that could be used in the course of deploying the COVID-19 vaccines. So there are just 5 topics I wanted to touch on quite briefly. The first is to sort of anchor us on the life course approach to vaccination. The second is to get specific on the recommendations for influenza vaccine. I also want to focus on health worker vaccination as one of the highest priorities for adult vaccination, then policies for vaccination of pregnant women, and of course, the opportunities for integration with primary healthcare services. So on this first issue of the life course approach to vaccination, here what you see on this slide is obviously the life course shown, and the breadth of vaccines that are relevant for different stages of the life course. This has been expanding quite a lot over the past decade or more. Now, previously, many children didn't receive vaccines beyond infancy. And certainly for males, some never received any other vaccine outside the scope of their childhood vaccinations. While for girls, they might receive and should have received tetanus vaccination during pregnancy. But what we see now is that on the top of the white boxes for all immunization programs, and then on the bottom half of the white boxes under each of the areas of life course are the recommendations for specific vaccines that are relevant for a region or a high-risk population or another bespoke component of an immunization program with specific characteristics. So we see that the target groups for COVID-19 vaccine, adults and older persons primarily, pregnant women also as high-risk groups, and then as a lower priority, the next priority would be adolescents. We see the overlap in these groups with vaccines that are targeted for these particular age groups. So this is a great opportunity for actually embedding more of the vaccine program for adults as we move forward. I'd like to move now to a little bit of data about the status of the life course vaccination. And this is shown by WHO region. And of course, I've put Africa, the Afro region at the top left of the slide so we can really focus on that. And what we see in this illustration is the status of the vaccination programs by countries within the region. So this is the proportion of the countries that have a universal recommendation for each stage of the life course. So for example, you see in the Afro region, but it's also true of the Sierra region, that for older persons, only a very small fraction of countries in those regions have a recommendation for some sort of universal vaccination for people in that age group. We also see that as you go in any of these regions, from pregnancy, newborns, and infant, where virtually every single country has universal recommendations for these age groups. As you go into older children, adolescents, adults, and then into older persons, virtually every region, this gets weaker and weaker in terms of the number of countries or the proportion of countries in this slide that actually have a recommendation. So if I move now to the next slide, I wanted to zoom in further in the African region. What this slide shows, and if you look at the legend in the top right-hand side, this is how you read these country charts. Across each of the 7 life course stages, so pregnant women, newborns, infants, children, adolescents, adults, and older adults, what we've done is we've plotted for each of the countries the vaccination schedule that was reported to WHO as of the end of 2019. And so each of these life course badges or flowers has 6 petals, each of them representing a stage in the life course. And at the center, representing the pregnancy life course stage. If the country reported a universal recommendation for a particular life stage, the petal is shaded in a darker color. And if a country reported a selective recommendation, they're plotted in a lighter color. And so what you see is when a petal is missing, it means that there was no recommendation for a vaccine in that particular stage of the life course. So I'll draw your attention again to older adults who are the primary priority for COVID-19 vaccine. And there are only 3 countries, Algeria, Mauritius, and South Africa, that in 2019 had a recommendation for a vaccine in that older life course. So again, every country now, if we plotted this for 2020 or 2021, would have that flower petal shown. And again, this is a great opportunity for expanding what's needed to protect older adults, as well as younger adults in the life course. So what are those specific opportunities? And I want to speak specifically about influenza vaccination. This is important for countries to implement influenza vaccine programs along with COVID-19 vaccine because of the known risks of serious illness for adults who are infected with influenza virus or with the SARS-CoV-2 virus. That's a substantial risk. And there's the potential for co-circulation of both influenza and SARS-CoV-2. So we could additionally address the stress on the healthcare system by co-vaccination, co-administration, or co-programming influenza vaccine. So from the recommendations from WHO, from the Strategic Advisory Group of experts, WHO does consider the co-administration of inactivated seasonal influenza vaccine and any dose of the COVID-19 vaccine as acceptable and are strongly encouraging countries and programs to consider this. Another opportunity is with healthcare workers. Again, a priority group, one of the highest priority groups for vaccination with COVID-19 vaccine. And in addition to COVID-19 vaccine, WHO recommends vaccination of healthcare workers for any of the routine vaccines for which there may be transmission as a healthcare worker or risk as a healthcare worker. And you see a pretty long list here of what those vaccinations could be. Obviously, this is something that is tailored within each country. So COVID-19 vaccination is a great opportunity to consider expanding and strengthening the remit of the health worker vaccination platform. And we do have implementation guidance for expanding the program under development and should be released in the first half of 2022. So where do things stand with respect to health worker vaccination coverage in the African region? This slide shows by country on the x-axis, and then the proportion of health workers who are fully vaccinated on the x-axis, on the y-axis. And you'll notice a curiosity on the scale of the y-axis, where for some countries, there is greater than 100% reporting, greater than 100% reported coverage of health worker full vaccination. These are data only from 23 countries. The blue dot represents the fully vaccinated population in total, and the colors represent the percent of the health workers that are fully vaccinated. this uses as a denominator the country reported denominators of how many health workers there are in the country. And this has been a challenge for a number of countries around the world to establish that database, that understanding of what the number of health workers is, especially under a variety of definitions. But you see here, the point of this is really to show a very broad range of coverage of health workers with a substantial number of countries that have fewer than 50% of health workers fully vaccinated within countries. And again, some of the most important populations to be vaccinated in order to protect not only their health from COVID, but also to protect the health system. So this is an area of substantial focus and substantial operational intervention to assure that countries are able to provide that vaccination to all health workers. The other opportunity is vaccination of pregnant women. I think people are fully aware, and shown on the right-hand side is the global tracking of national policies on COVID-19 vaccination of pregnant women. There is increasing evidence on the safety and effectiveness of COVID-19 vaccination during pregnancy, which suggests that the benefits of vaccination during pregnancy outweigh the potential risks in virtually every situation. So COVID-19 vaccination before pregnancy or during pregnancy is especially important in settings with moderate to high transmission or infection, or for women at higher risk of exposure to COVID-19 disease or specifically severe illness, which of course pregnancy is a risk factor for severe illness. So despite the well-established higher risks of COVID-19 among pregnant women, many countries are still not recommending vaccination for this age group. And again, that's what you can see in this slide here. Red countries are those that are not recommending. The orange ones are, the sort of pink color is those recommending, but with exceptions. The orange ones are where vaccination in pregnancy is permitted, but with qualifications. And only the blue and the green are the countries that have a recommendation for some or all, or a sort of a permissive recommendation for vaccination of pregnant women. Now, we do have clinical trials in pregnant women that are underway and continuing to monitor women who are vaccinated during pregnancy and their babies, which will certainly strengthen the data even more. There are three types of evidence that support the safety of COVID-19 vaccination during pregnancy, and that includes animal studies, post-marketing surveillance studies, where we especially do have a lot of data on the mRNA vaccines, and then studies of the mechanism of the vaccines. In other words, none of these are live viral vaccines. So really important platform, the Pregnant Women Platform, to interdigitate the vaccination of COVID-19. And then there are opportunities for integration of COVID-19 vaccine with primary health care. Again, much has been said about this is an objective to use the pandemic as a means to strengthen primary health care. And adult vaccination touch points are a major opportunity for both integration and advancement of other primary health care services and preventive health services. And here on this slide, it's this two-way street. It's both using these services as a means to roll out as quickly as possible the COVID-19 vaccines, and using COVID-19 vaccine opportunities to advance some of these services. So these are just some examples of primary health care services that could be dually used. We have on the right-hand side an integration resource guide for planning and strengthening of immunization services throughout the life course, which will serve as an opportunity to pull together the best practices that have been seen and the best recommendations we have on how we can use primary health care and integration to advance the life course immunization. So those are the examples that I wanted to draw out. I wanted to get really concrete on what it means to leverage COVID-19 for life course vaccination. What specifically are we talking about? And looking very much for countries to see within these what examples and what opportunities are most relevant at the country level. So I'll stop there and thank you very much.
Thank you very much, Dr. O'Brien, for this excellent presentation. Just one very quick question before you go, and before we move to the next speaker. How do you think we can work together, Africa CDC, WHO, to ensure that adult vaccination do not, promoting adult vaccination do not in any way affect the routine immunization for children, because that's still a big issue on the African continent? Over to you.
Oh, it's such a great question. And part of this is about, I really love the question because there's no interest that anybody has in sort of cannibalizing either healthcare workers, the cold chain, data systems, but instead leveraging all of those things to advance both the routine immunization program for children and the adult vaccination program. So this is about expansion and integration. And your point is so well taken that there would be no interest, and yet it is a risk that we end up taking from the essential immunization program in children in order to deploy to adults. So this is really about sizing the program, sizing the cold chain, sizing advancing healthcare worker training on immunization, and using the opportunities of healthcare workers who have not typically been involved in immunization to add to that skill set, so that any adult, any person of any age who has a recommended vaccine that they should be receiving has full, easy access to it when and where is most appropriate for them. And I think this is the huge opportunity that we have to also advance the essential immunization program for children to get at communities, families, children who are missing all vaccinations, what we call the zero-dose children, when their parents, when their elders are engaging with the immunization program and system. That's an opportunity also for the children in those families. And we've seen some great examples of that in countries. Nigeria in particular has been using the COVID-19 impetus to also drive at some of the improvements and zero-dose children and communities.
Thank you. Thank you. I'm so glad you could share that experience with us. Thank you, Dr. O'Brien. So we move to our final presentation for the day, and I'm pleased to welcome Dr. Benjamin Schreiber, who is the Deputy Chief of UNICEF Global Immunization Program, who will consider lessons learned from COVAX in implementing digital innovations and logistics to provide COVID-19 vaccines to the continent. Dr. Schreiber, thank you for joining us, and over to you.
Thank you, Dr. Mohammed. It's great to be here. I will share my screen now. Can you see this?
Yeah.
All right. And then I think the question you just asked, Kate, was excellent because, of course, we have to safeguard routine immunization, and we really have to work hard to not, one vaccine takes over all the work that's been done, and it's difficult. It's difficult to manage this. So I will give a quick introduction here on what's been going on in digital innovations and some logistics. I prepared a few slides. I will run through them quite quickly. One is like on digital health innovations, and the other part I thought is kind of really double down on logistics, what's happening on ultra cold chain. So I start off with something which is called DICE, which is a Digital Health Center of Excellence, which has been established to help and support countries in implementing and rolling out solutions that support the COVID-19 vaccinations, but also introducing innovations. We all have adopted a lot of innovations, of course, in our own personal lives. Yeah, we are now on Zoom. Everybody is now much more familiar with how to use Teams chatting and using cloud-based services. And we're seeing the same also in the health sector, that digital solutions are there and can be deployed. Yeah, DICE is not a funding mechanism, but it's aligned and supports what is done already. So I will talk a bit about this with some examples. So DICE has some priorities. There's a website as well you can go to with more information, but these are the priorities. It focuses on service delivery planning, vaccination status, counterfeit detection, and all of the other areas. And I will highlight now two of these examples quickly. This is how countries have been using geographic information system-based solutions for improving their microplanning priorities. Often, sometimes communities, new structures are being established and it's not on official maps. So how do you include new communities that kind of appear on the map and that you can identify them using geographic information systems and include them in microplanning, size them, and it helps you really uncovering populations that haven't been covered before. They will now be included in the routine immunization and the microplanning activities, and that's really an important tool. And we've used it for routine immunization, but it will also be very important here for the COVID vaccination. The other part is, of course, then real-time monitoring for logistics, deployment of vaccines. This is even more important given that a lot of the vaccines being deployed for COVID vaccinations have short shelf life, sadly. And there is a joint statement from the African Union and COVAX partners about the urgent need to change this. But given that there are short shelf lives, there's really a lot of importance to kind of be on top of where the stock are, how much stock is left over, and when it is decaying, and what needs to be done for reallocating this. Who supports DICE is a we've got private sector partners, we've got funders, we've got participating organizations, and it's a collaboration also between WHO and UNICEF. And really, this is kind of the support that DICE is providing guidance, technical assistance, business analysis, and helping to mobilize partners and building the capacity on the ground. So I run through this quite quickly because it's all online. I just wanted to introduce you to this opportunity. And this is where DICE is already supporting. 24 countries are using these services, and quite a few also in Africa. There are some projects already in progress, and some others have accepted and will start soon. So again, more information on the website. And I just want to introduce you this as one opportunity. And the reason why DICE was really established is we've seen a lot of innovation coming to countries, and countries we are kind of adopting new tools and solutions, but without really having the evidence base or the capacity to implement this. Then we had these innovations that then weren't sustained and failed. The other thing where UNICEF is working a lot on is, of course, on the ultra cold chain. You know that Pfizer products requires these ultra low temperature freezers. Even with a new formulation that will be launched in this year, Pfizer will require ultra cold chain. And few countries in the low and middle income space had really ultra cold chain capacity. Some capacity exists in Africa because of the Ebola vaccination. A few countries had this capacity and had actually excellent expertise that we could build upon, but it also provides an opportunity. The US government has secured 1 billion doses of Pfizer. It's kind of a very predictable supply for the next year, and countries can build vaccination strategies around this. So there's a need to build up this ultra cold chain capacity, and it's also helping to prepare countries for maybe upcoming or future Ebola outbreaks, because then the countries have already storage space for this vaccine in case they have this. And it's an opportunity to strengthen vaccine management, because if you don't only deploy the product, but also can provide technical assistance to support it. So here's what's been done. We identified that 60 countries, many also in Africa, were in need of this ultra low temperature freezers. We launched the procurement at risk to be quick, and to date have procured about 420 freezers to store up to 150 million Pfizer doses. And of these, sort of 315 have been now deployed and installed. We tend to buy them in a service bundle. That means not just like buying and dropping off the equipment at the airport, but making sure that this is really installed on site with people trained. And the installation period is on average only 12 days. So that's kind of quick to make sure that the capacity is available. So I call this the hardware space, but like all tools that are deployed, you need to think about the software, the human capacity. So we are deploying some innovative approaches. On the one hand side, it's this help desk that's open throughout the week and provides responses to countries within 24 hours. We provide private sector support with DHL and UPS, for example, that are providing support. And then UNICEF is also providing technical assistance in vaccine management in over 35 countries. And then altogether guidance and webinars and trainings have been held. So I want to conclude this now. My main points, I think, are procuring ultra cold chain equipment is relatively easy. And announcing a new digital health solution is also pretty easy, but it's really hard to implement it, and it requires change management. We have to talk with people, and I think Professor Tomori just highlighted that really there is a need for high-level political support and buy-in. Otherwise, we don't have these innovations sticking and being scaled up. So yes to innovation, but do it right. And thank you. That was my last slide.
Thank you so much, Dr. Benjamin Schrober. Unfortunately, we have run out of time, so I will not ask you the traditional one question, but really just to thank you for an excellent presentation on the use of digital and tech solutions in COVID-19 vaccine response. Thank you, Dr. Schrober. Let me hand over back to my co-moderator, Dr.
Ebere.
Dr. Ebere.
We've worked together for many years. Thank you very much. And so just to quick whistle around the key messages from this session, Professor Tomori emphasized the need to develop a common language between scientists, health professionals, and politicians to ensure that we have evidence embedded into our policy decisions. Justice Novignon indicated that health technology assessments and health economics may be part of that language that can make a more powerful impression on politicians to ensure that we get understanding of the necessity for investment in health. And Kate then introduced us to the opportunities emerging from COVID vaccination, that we might actually start to increase penetration for adult and special population vaccination programs for pregnant women and healthcare workers, as well as the older adults. And then Ben brought us to end to say that the logistics is not the problem, the solutions are there, but it is critical, bringing us back again to Professor Tomori, that there is a political commitment to implement them and abide by them. So thank you all to all our speakers. Thank you to my co-moderators and all the people, the team behind the scenes. This concludes the first part of this parallel session. And it is my pleasure now to hand you over to my brother, Dr. Ifeanyi Nsofo, who will be moderating the debate. And I can assure you this is going to be an exciting debate. Please stay with us, and Dr. Nsofo will come on now and talk you through the next session. Thank you very much to all our speakers once more, and enjoy the rest of the conference. Thank you.
Thank you.
Thank you.
Thank you so much, everyone, for staying back and being part of this particular session. Grateful to Dr. Kereke and Dr. Mohammed for moderating the last session and for all the speakers who spoke. My name is CPHIA-2021, and I'm a public health physician. I'm also a Senior New Voices Fellow at the Aspen Institute and Senior Vice President for Africa at Human Health Education and Research Foundation. And it is my honor to welcome everyone to this parallel debate. And the topic of our debate is innovations emerging from the COVID-19 pandemic response increase Africa's chances of achieving universal health coverage. So we have a number of debaters that will argue for or against this particular topic. Indeed, we must achieve UHC on the African continent if we were to move forward economically, ensure good health for our people, and prepare for future pandemics. Interestingly, the WHO defines UHC as a spectrum of care from health promotion to prevention, treatment, rehabilitation, and palliative care. So do COVID-19 related innovations have a place in helping Africa achieve universal health coverage? Before this morning, we had 4 distinguished debaters to help us unpack this question. However, one of our debaters, Dr. Stella Bosiri, is ill and is unable to join us today. However, we will not panic because the other 3 speakers are able to do justice to this topic. 1 will argue in favor of the topic, and 2 will argue against. And I need to reiterate finally that this kind of debates are really very important because they help us understand that policies are not straightforward. There are strengths, weaknesses, threats, opportunities in any policies being put forward, and it's very important for us to hear, everyone's voice in moving any policy forward. So please listen attentively because you will vote for the team that you think makes the most compelling argument at the end of this debate. Without further ado, let the debate begin. Our first speaker is Professor Isaac F. Adewale, and he's the former Minister of Health for Nigeria, and he's going to argue in favor of our topic. Professor Adewale, the floor is yours now. Thank you.
Thank you so much, Mr. Moderator. My co-debaters, our enlightened audience, distinguished ladies and gentlemen. I thank the organizers of this wonderful program for the opportunity given to me to be part of this debate. My task is simple and is to present to you that innovations emerging from the COVID-19 pandemic response increase Africa's chances of achieving universal coverage. By universal coverage, I simply mean quality health care being offered to our people that is accessible, that is affordable, and within reach of many of our people. The SARS-COVID pandemic has challenged health systems worldwide. Uncertainty of transmission, limitations of physical healthcare infrastructure, and supplies, as well as workforce shortages, require dynamic approaches in many of our countries. And these are led to the innovations that will be presented to you in the course of this debate. Distinguished ladies and gentlemen, I will structure my presentation into several areas. I will talk about innovations in health technology, innovations in prevention, innovations in surveillance and reporting, innovations in detection, innovations in response, and then go on to talk about innovations in vaccine development, innovations in terms of technology, in terms of health workforce training, and so on and so forth. Distinguished ladies and gentlemen, with the advent of the pandemic, we've been able to develop innovative ways of reducing transmission, including appropriate measures for reducing social contact. We've increased our ability for surveillance and reporting. We've increased our ability to detect the virus and able to make diagnosis, including rapid diagnostics. In addition, we've also improved our ability to respond effectively to the pandemic, including rapid development of PPEs across, encouragement of One Health approach, self-driving disinfection robots, and infection-proof transportation modules. Distinguished ladies and gentlemen, the list is endless. We've been able to increase the number of medical personnel trained in infection prevention and control. Not only that, we've developed enhanced capacity for molecular detection of the virus. A total, for example, in Nigeria, a total of 156 molecular laboratories were quickly equipped and accredited by the Nigerian Center for Disease Control. The labs were all equipped with real-time PCR, while cartridges were actually acquired for labs with GeneXpert machine. 38 oxygen plants were approved and currently being funded for reactivation and development across the country. In Nigeria, within a rapid space of time, we've been able to test over 4 million people, which is quite an innovation in a country where people are reluctant to come forward for tests. As at the last count, the government has released about $60 million for development of 52 isolation centers across the country, and these isolation centers can be repurposed as infectious disease hospitals. Not only that, we've developed cold chain capacity for storage of vaccines across the country, which will also be useful for vaccine storage for other vaccine preventable illnesses. In addition, we've developed telecommunication facilities that will allow for social distancing, improve medical education, use of data management, and use of electronic medical records. Also, during this COVID era, we've been able to develop vaccine within a period of 1 year, which is of tremendous importance. The first vaccine, it took about 20 years to develop the first vaccine, but for the COVID-19 vaccine, it took less than 1 year. And as of today, we have vaccinated about 8.3 billion, and we delivered about 8.3 billion doses of vaccine globally. This is quite an innovation. Data from US indicated that vaccines have prevented about 1.1 million deaths and about 10.3 million infections. These are quite innovative. The last session also talked about innovations in digital healthcare, which has actually been facilitated by the COVID vaccine. Mr. Moderator, co-debaters, distinguished ladies and gentlemen, I am quite hopeful that I've been able to convince you that the innovations that we've put to bear, that we have displayed and put to use of our people over the last 2 years have actually helped to improve our response and our ability to achieve universal coverage. Thank you.
Awesome. Thank you so much, Professor Adewale, firing from all cylinders. Very great point. And I'm happy that Dr. Ebere Okereke is going to step in for Dr. Bosiri to argue against the topic. So, Dr. Ebere, sorry, to argue for the topic.
Thank you.
Okay, so Dr. Ebere Okereke, over to you. Sorry, not Dr.
I'll follow. I'm supporting Prof, so I will follow subsequently.
Yeah. Sorry about that. So Tolu, the next speaker is Tolu Adeleke. Tolu Adeleke Ire, and she's the CEO and founder of Tolu the Midwife, who will present arguments against the topic. Tolu, over to you.
Thank you very much, Dr. Nselfo, and good morning, good afternoon to my co-debaters and to our audience. So I do not believe that the post-pandemic innovations will increase the chances of achieving universal health coverage, because I believe in Africa, because I believe we're introducing new systems, processes, policies. When do we really understand why the systems that are existing are not working or may have failed? And how are we trying to rectify the problems in healthcare? So according to the World Health Organization, there are 6 essential components that are essential to achieve universal health coverage. So they are people, policies, products, services, information, and finances. I'll cover, for the sake of this debate, I'll cover 3 of those points. So people, policies, and services. In Africa, so for people, in Africa is hemorrhaging healthcare professionals, so your nurses, doctors, allied health professionals who are fundamental in achieving universal health coverage at an alarming rate. So as an example, the UK are aggressively recruiting healthcare professionals. From the Nursing and Midwifery Council in the UK had registered almost 10,000 new nurses from 11 African countries, and that leaves us in Africa depleted. So moving on to policies. So with policies, we cannot make policies without people. Policies for innovation and change must include community engagement at every step. And the benefits of including the community is it will foster trust. You also have an understanding of the local problems, and then you can create solutions to address these problems. You empower the citizens, and then you also increase the chances of innovations that you may be implementing to be successful. It increases the chances of it being successful to achieve universal health coverage. And last but not least, let's talk about services. So it is unfeasible to achieve universal health coverage when all the essential services are not available in the local communities. So it appears that there's a lot of information about the big three diseases. So malaria, HIV, and AIDS, and tuberculosis. But then what happens to diabetes? So the non-communicable diseases, diabetes, cancer, hypertension. I read in a recent article as I was researching for this debate that the rate of people who are dying in Africa from cancer has exceeded the rate of people who are dying from malaria, TB, HIV, and AIDS combined. So that says to me that we need to focus more on other services and push them into the local communities in order to actually achieve universal health coverage. And then finally, health promotion, health prevention, and early detection of diseases should be managed in primary health care centers. And then if we manage it in primary health care centers, it reduces the chances of it leading to a mortality or a morbidity. So expecting the post-pandemic innovations to increase universal health coverage is aspirational, but simply not realistic. Thank you very much.
Awesome. Thank you so much, Tolu. Great points once again. And I mean, the point you made about universal health coverage in one place in the UK, our health workers are hemorrhaging from the continent to the UK, and where does that leave us? Thank you very much. And I hope that listeners are listening, because you're going to vote and decide which of the teams makes the most compelling point. Okay, so my honor to introduce Dr. Ebere Okereke to argue in favor of the topic. Over to you, Dr. Okereke.
Thank you very much, Ifeanyi, and thank you to the earlier speakers, Professor Dewole, for making the case about the innovations that have emerged. And Tolu, I'm actually really grateful for you for outlining the characteristics, the criteria for universal health coverage, because that is actually my jumping off point. And the critical thing, I would say, the first and most important, I agree with you wholeheartedly, is people. Engagement of people, but I'm looking at it from a slightly different perspective. The biggest challenge for universal health coverage and for political commitment to it on the continent has been the limited agency of our citizens in actually recognizing that they have the power to mandate that their governments that they elect prioritize health. So what has COVID brought to this picture? Everybody is talking about health. Everybody is talking about the capacity in their countries. Everybody's asking the question, why don't we have? Why do they have and we don't? So this dialogue on health, and that is actually buttressed by the work that we're doing around risk communication and community engagement, means that we are actually developing a citizenry with agency, and that will demand from their elected governments that they meet their Abuja Declaration, they strengthen their health systems. And I think we are therefore much more likely to achieve universal health coverage due to citizen pressure as a consequence of the opening of the dialogue that COVID-19 has increased. In terms of innovation, again, I want to take innovation away from the technological innovation back to my favorite subject, the innovation about people, how we use people. Now, if we remember in the 2014-16 West Africa Ebola outbreak, the Nigerian health system actually deployed polio responders and used them differently. In COVID, we've actually expanded that. There's a huge expansion in cadre of people we wouldn't traditionally describe as healthcare workers who have been trained to be part of the COVID response. They are our system. They are actually going to be part of the delivery of universal health coverage. it's going to allow us to actually start to think beyond doctors and nurses when we think about health system staffing. We need to start looking at these community health workers, voluntary and paid and innovative ways of using these people who we've now trained and engaged to move to the next step, to broaden that, to support the existing systems, and to start looking at universal access. And then a final point that I want to mention is actually, or two more points, the political perspective. The heads of presidential, almost all our COVID response systems are being led by the president's heads of state with very clear engagement of finance ministers. This is one of the challenges that we've had in the past, is that finance ministers have seen health as a drain on resources and not an investment. But what COVID has shown is that if you haven't got health, everything else is not going to happen, is secondary. Our economic development, our economic expansion has all stopped as a consequence of COVID. And it's only those countries whose health infrastructure has allowed them to respond promptly who've been able to get back on track. So I think we now have heads of state who get it. We now have ministers of health who are actually talking health. And that is an opportunity to say, so while we're at it, let's go back to that primary thing about UHC. And then my final comment here is around regionalization of health infrastructure. And it talks to your comment about professionals, health professionals being sucked up by the global north. And it is not a popular thing, but it is reality that this pandemic has shown that we're not all in it together. The global north has been very protective of itself. The global health architecture has proven to be skewed towards the global north, and therefore Africa has stepped up. The African Union, after CDC, a lot of our other African institutions have actually stepped up and started to deliver. As a health professional myself, I know that the biggest challenge to working in Africa is having an organization that you can be effective from. This pandemic has actually strengthened those organizations. So most people are going to think, nobody wants to go and live in a country where you get asked where you're from originally, if they have a choice. If they have an organization that they can work with and be valued, we do know that money is important, being paid is important, but job satisfaction is the major driver of where health professionals take their skills. So with these strengthened organizations, they're going to stay and they're going to help us build a system. So I feel very strongly that this COVID pandemic, and being a consultant in communicable disease control, we have a saying, never let an outbreak go to waste. We have not. We need to build on these opportunities and move it on to universal health coverage. Moderator, I rest.
Thank you so much, Dr. Okereke. I mean, it's, for me, my major takeaway from what you've said is without health, we have nothing. You know, and without innovations, we don't have health and all. Thank you so much, Dr. Okereke. Now, let's move on to Dr. Ayodeji Udutolu, who is a senior health specialist in the African region at the World Bank, and he will be arguing against, just like Tolu. Dr. Udutolu, over to you.
Thank you very much, Mr. Moderator, and I want to thank my co-debaters, particularly thank Tolu for laying the foundation, a very strong foundation indeed, for this argument. That all this COVID pandemic, innovations cannot help us, to achieve universal coverage. We have to look beyond that, to some other things. Let me start from the premise that there is a basic assumption that our opponents, have taken on, which is erroneous. We are not yet post-COVID. If we think that we are done with COVID, COVID is not done with us yet. So we still have a battle ahead of us. And when you have, you know that when you have this type of situation where we have not contained the virus, we are dealing with uncertainties, several uncertainties, but there are things that we know that are certain. One, let me say that I see the period 2010 to 2019 as African Renaissance. Our economy was growing. We were developing our own grown solutions to the health problems on the continent. 2010 to 2019, we have very good, stable environment for us. Then COVID came. I regarded that period as African Renaissance in health. But what we have seen is that COVID has aborted our Renaissance, and we have to go back and think on how to do this. I've mentioned that there are many uncertainties because we have not contained COVID yet. The Lancet Commission on the Future of Health actually identifies two key areas. One is the convergence of health, looking at reproductive health and all these other diseases combined together, and emerging diseases. There are two tracks. COVID is just one track of it. The other track has to do, with all the problems that we have in Africa, both in terms of preventable diseases. We have NCDs going on the continent, and things like that. There are some things that we know. One, the macro environment tells us that what our opponents are proposing is not based on the actual fact that we have on ground. One, talking about the economic growth. We have many countries contracting, and we have many countries going into recession. Three important African economies: Nigeria, South Africa, Egypt. So where are you going to finance this innovation? Where is the money going to be coming from to get the infrastructure that you need for technology and all this in place when we have serious economic growth problems? The second thing is the debt burden of our countries is rising. The third is inflation. When you look at all this combined together, we have a situation where even the little that we have cannot buy much because of inflation. And when we talk about overseas development assistance, northern countries are grappling with their own problems too. And that's why we see this division in vaccine here, vaccine not there, because they have to contain their own problem. So what I'm saying in essence is, one, we have to focus and contain to move on to some other thing. The second thing I want to say, the work that was done by my colleagues, Gil Shapira, Tashrik and others, tells us that there are a lot of distortion on the continent. At the beginning of COVID, we have 30 to 60% disruptions of services. All the gains that we have before 2019, almost all of them were wiped away, by COVID. So that is a very serious problem for us to be able to look at. And that tells me that if we don't do a system approach and we focus on innovation alone, we will not be able to achieve universal coverage. The other point I want to bring is zero in on the innovation itself. Innovation does not drive itself. People drive innovation. People drive innovation, just as Tolu was saying. Many of us, our audience, every one of us, we have iPhone in our pocket. Somebody will have iPhone 8, iPhone 7, iPhone 8. It starts from iPhone alone. So you need people to drive innovation to take it to iPhone 14 that we are now. So when we look on the continent in terms of leadership for innovation, government is not the place to grow innovation. Innovation grows in the private sector. If you look back in history to innovations, I've been in innovation in the past 20 years. I know innovations are driven, one, by the military, innovation by the private sector. It's not the government. Government is so bureaucratic. Government is so risk averse to be able to drive innovation. So when are we talking about innovation, changing the platform for us to be able to achieve universal coverage? What are we talking about? Okay. There is a second thing which the other side is not looking at, and that is the diffusion of innovation. It takes time before innovation diffuses to the level that you can use it to get universal coverage. I'll stop there. Okay. I hope I have another opportunity to bring in some other points that I have. Thank you very much for having me.
Okay, thank you so much, Dr. Dutolu, and you have spoken like the man with the money because you made the money argument strongly. So we have 6 minutes left, and I'm going to crave your indulgence for your rebuttals. Please use 1 minute each for your rebuttal. So over to you, Professor Adewale, 1 minute.
Thank you so much, Mr. Moderator. I'm quite delighted that actually our opponents spoke for us. It appeared as if they did not understand the issue at hand. The question we are supposed to address is that the innovations emerging from COVID-19 pandemic response increase. That's the emphasis, increase. It's not talking about achieving universal coverage. Increase our chances. That's what we're saying. And I'm quite surprised that they went off track. None of them actually contested those innovations we have mentioned. Innovations in the area of prevention, in the area of surveillance, in the area of detection, response. The oxygen plants, for example, in Nigeria, deployment of about 8 billion doses of vaccines worldwide. The cold chain system in Nigeria and many other countries, digital health, vaccine deployment. Are they not innovations? Are they not there? Would they not continue to be used even after the pandemic? Thank you, Tolu and Dr. Dutolu, for supporting our position.
All right.
I distinguished and enlightened audience, I'm sure you agree with me that the innovations will certainly increase our ability to achieve universal coverage. Thank you.
Thank you so much, Professor Adewale. I feel that if a script was being submitted to you at this point in time by the opponents, you mark them, they will fail, woefully. So over to you, Tolu. 1 minute, please.
Thank you very much, Dr. Fine. So, Professor, just to say, I understand that it seems like we were arguing against, but you said a few things that I struggled with. I struggle to accept because yes, we are building all this. There's amazing innovations right now because of COVID. One thing you mentioned was telecommunications. How will we exactly use telecommunications to improve health? How will we use it for health promotion after COVID, whenever COVID passes? That's one thing. Another thing that Dr. Berry, and I know this is not meant to be addressed at her, but another thing that Dr. Berry said was that the heads of states are recognizing the importance of sponsoring health or funding health appropriately. Well, we all know what's happening with the Abuja Declaration. We are nowhere close to our government in Nigeria contributing 15% of the annual budget towards health. And in the middle of a pandemic, our country in Nigeria reduced the health budget by 40%. So I can't speak for the whole of Africa, but if we're just looking at Nigeria alone, we've gone, like my co-debater, Dr. Wale said, we have gone years back. So all the progress that we had made prior to 2019 has gone out of the window, and our government still do not recognize the importance of funding health appropriately. Thank you very much.
Thank you so much, Tolu. Dr. Okereke, what do you have to say to that? 1 minute or less.
Well, in 1 minute, I will stress that finance is essential, but it's not the absolute, the only thing required for universal health coverage to be achieved. We'll take Cuba. Cuba is a very poor country. They have comprehensive health coverage. And so what we need, and the difference there is a political commitment. So I agree and I acknowledge that during the pandemic, due to the shrinkage of the economy, decisions have been made around budgets, including cutting health budgets like in Nigeria. But there is a difference in thinking now that we have. And I go back to what I said at the beginning about pressure to recognize the necessity for investment in health as a prerequisite for economic growth. And that hasn't changed. I think that if we look at what we're looking for here is a change in the political mindset. The fact that Africa CDC has been able to convene all the heads of state, presidents, and on all elected heads of state for 55 African Union members 4 times in this pandemic to discuss health. It's never happened before. So we have this opportunity to leverage to start to get that political commitment. The money will follow. I feel strongly about that.
Okay, thank you so much. Harley, please, you can start the poll now. Dr. Dutolu, over to you. The last word.
Yeah, I quite recognize the point that our opponents are making, trying to twist the story at the end of the day. The fact that they listed innovation does not mean innovation will bring the change. The fact that they measure all this oxygen cylinder and everything, we know what has happened before. All those gains that we have with every epidemic, by the time 5 seconds, it fizzles away because there is no leadership. There is no leadership to drive. Innovations in private sector are driven by vision of leaders. Now, we don't have that in the health sector. Thanks, Ebere, for our head of state are now waking up and they are coming together and all this. Yes, they must show us that this is not like a flash in the pan. That is something that is consistent and will be sustained, over time. I think we've made our points. We need money, we need people, we need everything to sustain innovation, to translate into health for our people, not just listing them. Thank you.
Okay, thank you so much, my debaters, Professor Isaac Adewale, Tolu Adeleke Are, Dr. Ebere Okereke, Dr. Wole Udutolu. And already, we have deployed the poll. What do you think? Will innovations emerging from COVID-19 help increase Africa's chances of achieving universal health coverage? The polls are coming in. So far, it seems as if more people are voting in favor of the topic. But let's just give it another 30 seconds. We don't want to be accused that we rigged this particular poll. We want it to be very plain and open to everybody. Yeah, but thank you so much for such an engaging discussion. I know that 30 minutes is not enough to do justice to this, but I think we've really succeeded in, putting out very strong points for and against. And ultimately, I know that each and every one of us really wants universal health coverage to become a thing on the continent so that we can have a better future for our people. So Hanley, any updates on the polling so that we can end now? I think we're 1 minute. Okay, there you go. 78% in favor, 22% against. So Professor Adewale and Dr. Okereke, congratulations. And Tolu and Dr. Dutolu, I mean, you've made your points, and I'm sure that probably if we had more time, who knows, the voting may have been reversed.
Yeah, because people love aspirations. the reality is down the road.
All right, thank you so much, and I think we've come to the end of this debate. Thank you, and enjoy the rest of your day. Yeah.
Thank you.
Thanks, everyone.
Hmm.